Hi everyone, welcome back to UWorld's Next Gen NCLEX Review. My name is Samantha, I am a nurse here at UWorld, and I'm so excited to see you all back joining us today. So in today's lecture session, we're going to be diving into chronic kidney disease, or CKD for short. Kidney issues are so prevalent in a hospital setting, so if you plan to work inpatient, this is definitely a topic that you are going to want to be comfortable with. And for all of our NCLEX preppers, there will be questions throughout today's lecture, so you can make sure you're staying tuned in, and they're just challenge questions throughout the way so we can make sure that we're understanding all of the information. So let us know in the comments when you test, or if you've already tested, so we can either wish you good luck or congratulate you on passing. This live will be on demand after we are done today, so you can tune in on any of our social channels to find it. Personally, I find our YouTube channel as the easiest one to search with the search functionality. So if you have to join late, you duck out early, no worries. You can always catch it after we're done on your favorite social media channel. As always, drop your comments and your questions into the chat, as well as your answers to today's questions. We have the wonderful nurse Jasmine moderating for us, so we want to hear from you guys. We love an active chat. Drop those comments, questions, and answers in there, or even just stop by to say hi. So before we start with today's CKD material, let's start out with a question to get us warmed up. So chronic kidney disease, no shocker here, it involves the kidneys. Can you guys name 3 main functions of the kidneys? So question out here, let's get it started. What are the 3 main functions of the kidneys? Alrighty, I'll give you a few seconds. I know we're starting out with a question. Our brains aren't even warmed up yet. But in the meantime, a reminder that we go live 5 different days a week, 7 times a week. You can find our full schedule at uworldnursing.com, as well as other important information. It's sort of like a home base for all of our UWorld nursing social efforts. So I see a couple of answers coming through, and it looks like Aminata used UWorld to pass the NCLEX. Congratulations, that is so exciting. Congrats on all your hard work. And I see a lot of different answers coming into the question. A lot of you guys got this. I see a lot with filtration, filter, excrete. You guys, per usual, actually absolutely nailed it. So our 3 main functions of the kidneys are going to be to excrete, to filter, and to produce. So let's break these down. What are we excreting? We're excreting the body's toxins through that GU system. We are filtering. The kidneys decide what should the body hang on to, what should the body be getting rid of. And these components include things like electrolytes, fluid, waste products, and toxins. To produce is the last of our functions here. So what are the kidneys producing? They're producing a hormone called erythropoietin. So this is produced and emitted by the kidneys, but it plays a bigger role in the body as a whole. So what it does is it stimulates and signals for the bone marrows to release red blood cells when that red blood cell count is running low. So a great way to remember what erythropoietin is and does is by linking it down to its components. So the medical name for a red blood cell, what erythropoietin is working to stimulate is an erythrocyte, which makes erythropoietin a little bit easier to remember when you link it to its function and its main component. So with that being said, to filter, to excrete, and to produce are our 3 main functions of the kidneys. Now let's move into chronic kidney disease. So we know this is a slow onset. It may be referred to as an insidious disease, or one that just takes a very long time to progress. So this disease will take years to advance to end stage, which you can hear referred to as end-stage kidney disease, or ESKD. You may also hear this called end-stage renal disease, ESRD. It's the same thing. So it's important to remember that CKD is irreversible, meaning the damage that's done to the kidneys in this disease cannot be undone. There's nothing we can do to go in and take it back. So how do we classify these diseases? We classify it within 5 stages, and we make these classifications using something called glomerular filtration rate. Now that's a mouthful, so we're just going to call it GFR for short. But remember back to when we discussed those 3 main functions of the kidneys, and we know that to filter, or filtration, was a big one of our functions. So that filtration that's happening is referring to a part of the kidney called the glomeruli, and this is where we get glomerular filtration rate. So it calculates the blood that is filtered by the glomeruli of the kidney, and it's measured in milliliters per minute. This is how we stage the 5 stages of CKD. So remember, in the 5 stages, the higher the number, the worse the damage is. So in stages 1, 2, and 3, here the kidneys are still functioning, but we see that GFR gradually decreasing. Essentially, the kidneys are filtering less and less blood. Our key nursing interventions here are to assess the existing damage, monitor these clients closely, and most importantly, prevent further disease progression. Unfortunately, if we are unable to stop the disease progression, these clients will end up in stage 4 and 5. Here, the kidneys have become severely impaired, and we start to consider more invasive options, things like hemodialysis if it's needed, or dialysis, as well as maybe even a kidney transplant. So what are our big causes? I'm going to take a little break and answer. I see a few questions in the chat. And someone asked, is there a place to watch these even when they aren't live? Any of our social media channels are going to have all of our past lives on them. We upload them almost right after we do it. Personally, I think the YouTube channel is the easiest one to search. So you're always able to watch these even when we're not live. We do post them all afterwards. And someone's asking for the price of a 1-month subscription. Please go to uworldnursing.com and you can find a buy now button that's going to explain all of our different purchase options. So tuning back into CKD, our causes, our most common red flag causes are going to be diabetes mellitus and hypertension. Now, I think of these as sort of like a triangle. Whenever you see kidney issues, a lot of times you see hypertension and diabetes lumped in there. They're all so closely related. So why do these cause CKD? Diabetes leads to that persistent state of hyperglycemia that results from the diabetes mellitus, and this can damage the tissues of the body, including the tissues of the kidneys. Now, hypertension works to cause kidney disease because this consistently high blood pressure, high pressure of blood flow can damage many of the body's tissues, which includes blood vessels and arteries. And speaking of arteries, the most important artery that feeds the kidneys is called the renal artery. This artery, when it's damaged, in turn will limit blood flow through the kidneys, which in turn decreases kidney function. So we talked about glomerular filtration rate being the amount of blood the kidneys are able to filter. They're not going to be able to filter very much blood if we're not able to get blood into the kidneys. So when we see damage to that renal artery caused by these high blood pressures, this is a big cause of CKD. Other causes can include autoimmune diseases like a glomerulonephritis or a genetic cause like polycystic kidney disease. Alrighty, so we're going to jump to our clinical features table here and look into a lot of these manifestations. So a lot of these are going to be fluid balance based because we know that our kidneys excrete and filter our blood. So volume overload, these kidneys here, they're not working at full capacity. We see that gradually decreasing GFR. They're not excreting what they need to be excreting, and this will manifest in a couple of different ways. So we can see peripheral edema, which looks just like generalized puffiness. We see this manifest first a lot of times in the ankles and the feet. We can see pulmonary edema, so moving into our lungs. We'll hear rales upon auscultation. We can also refer to this as crackles. It's kind of like a popping, like crackling sound. I think of Rice Krispie treats whenever I see this. Pleural effusions, another potential manifestation of CKD. So here fluid has infiltrated the pleural space in the lung, which is going to limit the lung's ability to expand and get good breath in. So it limits the amount of air a client is able to inhale. Really important one here. And lastly, hypertension. When we see this volume overload, we see more volume in a system of the same size. That is going to increase our pressure. Another big category of side effects will be accumulation of waste products. So we can see pruritus here. Toxins accumulate in the blood. They eventually make their way into the interstitial space. And when they come up to the surface of the skin, a client may experience lots of dryness, which is going to lead to itchiness as a result. We can see the buildup of toxins in the blood because the kidneys are not filtering properly, and this can impact our neurological system. So clients can become lethargic. We can see sleep changes and peripheral neuropathy, which is that numbness, tingling in the feet and the hands especially. We see a lot of changes in the electrolyte balances. The kidneys are supposed to be mitigating this, and when they're not working, they're not going to be controlling our electrolytes properly. So we can see high serum potassium, hyperkalemia, high serum phosphorus, or low serum calcium, which would be hypocalcemia. We can also see the potential for disruption of the acid-base system, conveniently enough, just next week, next Tuesday, we're going to be doing the ABG live. So if you have any questions about this, next Tuesday, we're going to be back on it. No worries. But we see toxins and electrolytes accumulate in the blood, which lead to an increased state of acidity. This is a state called metabolic acidosis. So again, more on that in our ABG lecture next Tuesday, but really important to know that we can see metabolic acidosis come from CKD. Clients can also be anemic. So remember when we talked about that hormone just a few minutes ago? It's the one that the kidneys produce and the one that stimulates the bone marrow to produce red blood cells. I'm going to ask another question to the chat. Who can remember what the name of that hormone was? It is linked to why these clients are going to be anemic. Alrighty, so again, what was the name of the hormone that the kidneys produced? I'm challenging everyone's memory here. Alrighty, I'll give you a few more seconds. Drop those answers in the chat. Who can remember the name? Alrighty, and I see a lot of people, way to go. You guys have killer memories. There's no tripping you up. Erythropoietin was what I was looking for. So again, it's related to the medical name for the red blood cell, which is an erythrocyte. So we see erythropoietin when we don't have enough of this because the kidneys produce it. When the kidneys aren't working at full capacity, they're probably not making enough of this, meaning they're not stimulating the bone marrow to produce and release those red blood cells, meaning the clients can become anemic. So erythropoietin, yes, really important here. No red blood cell production equals anemia. And lastly, one of our last manifestations that we can see due to CKD is bone disease, such as osteoporosis. And this is again related to that low serum calcium or the hypocalcemia. So now that we've talked about all of these really unpleasant manifestations of CKD, what can we as nurses do to help these clients? So management of CKD, we're going to pull up a table here. It's a pretty simple one. Don't get too excited. But management here is going to be twofold. It really only applies to stages 1, 2, and 3 of CKD because here the kidneys are still functioning. That GFR has decreased, but it's still able to function. And we're really, really trying to prevent further damage because once we're end stage, once we're stage 4, stage 5, we have to consider more invasive options. And again, it's irreversible. So there's nothing we can do to undo that damage. So management is twofold. We're going to look at medications and we're going to look at diet. So medications is where we'll start. What are we going to do pharmacologically for these clients? So we're going to treat that hypertension because so often, like I said, we see hypertension, diabetes, and kidney issues are all closely related in a little triangle. So for hypertension, we can give like an ACE inhibitor, an ARB, which is an angiotensin II receptor blocker. This helps to decrease the body's blood pressure to prevent further damage to those renal arteries, which is going to prohibit and limit the amount of blood flow through the kidneys. And the less blood flow we get through there, the less those glomeruli can filter. So ACE inhibitors include our prils, like a lisinopril, a captopril. Another bonus question today, what are common nursing considerations for ACE inhibitors? So what kind of clients can we not give this to? What's a really common side effect of an ACE inhibitor? What's a dangerous complication of an ACE inhibitor? I'm going to ask you guys that. If you know anything about ACE inhibitors, drop that in the chat and I will check in and see who got it right. But I know you guys are going to do fabulous. We can also give those ARBs that I talked about, like those are the sartan families, like a losartan, a cosartan. These are really common medications. We want to treat the anemia. So we can give things like erythropoietin injections because the kidneys are probably not making this in enough supply. We can also supplement with iron, really important here. We want to help restore that anemia or decrease the anemia and help stimulate that bone marrow to produce more red blood cells by supplementing with erythropoietin injections. Now going back to our ACE inhibitor question, you guys absolutely got it right. Angioedema is a really, really scary complication that we can see from ACE inhibitors. I see someone said is contraindicated in pregnancy. Absolutely true. And I see productive cough. We can see dry cough from that is a common side effect. That is not necessarily enough to get them to discontinue the medication, but it's a common side effect. Again, if we see angioedema, we would want to abruptly discontinue it and seek medical attention, and we don't give it to our pregnant clients. But you guys absolutely nailed that. Way to go. We clearly don't need to do any more pharmacology pharmacology today. So we want to also help to reduce that volume overload. We can do this to reduce the edema by giving a diuretic. So it's going to treat that volume overload, but important to note, the body is really only going to respond to these diuretics in those stages 1, 2, and 3 of CKD. Because again, these kidneys here are still functioning. They're still able to respond to those diuretics and diurese or excrete that excess fluid. We want to fortify the bones, and we can give that by doing supplements of calcium along with vitamin D for absorption. And we want to supplement to make up for that low calcium or that hypocalcemia that we know these clients can suffer from. We also want to treat hyperkalemia if it appears in these clients. So we know that hyperkalemia and potassium imbalances can cause cardiac complications, can cause really dangerous dysrhythmias. Now, if you have any questions on this, last week we just did an electrolyte lecture based on and specific to potassium, covering hyper and hypokalemia. So if you have any questions on that, go ahead and check back in with last week's lecture. That's a great way to use it. But we want to treat hyperkalemia because we know this can have cardiac complications. Our first priority, I'm going to give you a little hint, wink, wink. You may see this in a question later. It's going to be to stabilize that cardiac membranes. We want to protect the heart and stabilize those cardiac cells. And we do that with IV calcium gluconate. This treats the dysrhythmias. It treats and stabilizes those cardiac cells, but important to note, it does not actually decrease the potassium, but stabilizing the heart is our first priority because remember our ABCs, airway, breathing, circulation, dysrhythmias affect that C or the circulation. That's going to be our first priority. After that, we're going to do things that are going to help to decrease our potassium or excrete it, maybe shift it intracellularly. This can be things like sodium zirconium, a K-exolate. These will get rid of it through the GI system. We can give insulin paired with dextrose, which is going to shift that potassium intracellularly, getting it out of the blood and reducing our hyperkalemia. And all good things. We can also give a nebulized albuterol. We can give bicarb, a couple of different ways that we can decrease our serum potassium, We want to work to decrease phosphate or that hyperphosphatemia. We can give a calcium acetate for this, maybe a calcium carbonate. And lastly, if this puts the client into metabolic acidosis, we're going to need that. Now, just a quick little overarching, again, we'll cover it in more depth next Tuesday with our ABG lecture, but whenever acid is high, we need more base. So a common treatment for this would be giving sodium bicarbonate. You may have heard this in a clinical setting simply as bicarb, but that's going to help adjust for the high acid by giving more base. Quick little chemistry lesson there. All right, so medications were the first part of our twofold effort for these CKD clients. The second is going to be diet. Now, dietary changes require a lot of teaching, a lot of patience. It's hard to completely overhaul your diet. But in these clients with CKD, there's a couple of things they need to avoid. So first and foremost, they need to be on a low potassium diet. So quick question, what do you guys know is high in potassium that these clients are going to need to avoid? So what are high potassium foods that a client with CKD will need to avoid? Go ahead and drop it in. Miss Independent asked if we're just starting. We started a few minutes ago, but no worries. We post all of our lives to our social media channels afterwards. It'll be up probably by the end of today, so you're always able to check back in and see what you missed. I think the YouTube channel, again, is the easiest one to go through and search for whatever topic you're looking for more instruction on. All righty. All right, and someone says the link doesn't direct to trial. If you want to go to uworldnursing.com, we have a buy now link, which takes you to our actual product to purchase. And I believe the 7-day free trial link is down at the bottom, but you may need to double check that. If not, you can always just Google UWorld Nursing 7-day trial and it will pop up. All right, lots of great answers coming in. Way to go, you guys. I see lots of things like fruits here, avocado, tomatoes, oranges, bananas. Absolutely, you guys nailed this. So our high potassium foods here are going to be things like bananas, oranges, orange juice, apples, leafy greens like spinach, like kale. These are all things that these CKD clients are really going to need to be limiting or completely avoiding. We want to make sure they're on a low phosphorus diet as well. So avoiding things like nuts, and berries, and again, those green leafy veggies. So good news for anyone that's not a salad fan. Low sodium. We know where sodium goes, water will follow. These clients are already volume overloaded in most cases, so we're going to want to limit our sodium. We're going to avoid really salty foods, really processed foods as a general rule of thumb. Things like popcorn, like chips, like fries, like burgers, like hot dogs. A lot of those processed meats are really high in sodium. As yummy as those sound, we are going to need to limit them. Clients will be on a fluid restriction because we don't want to add to that fluid overload they're already experiencing. And tricky one here, a lot of clients will be on a moderate protein restriction. Now that sounds kind of confusing. Obviously protein is such an important nutrient to the body, but breaking down protein, pretty tough on those kidneys. They're already struggling due to that CKD. We don't want to overload them, overwork them more. So for a moderate protein restriction, we're not going to completely cut it out, but we are going to limit it, and we're going to try to stick to our lean protein sources, our meats like chicken, fish, plant-based protein, maybe a tofu. Beans are another great source of this. And we're going to avoid those really heavy, really processed things like red meat, steak, sausages a lot of times, processed cured meats like hams. Those are things we're going to try to avoid and replace it with a limited amount of leaner protein sources. Alrighty, someone says canned foods. Yes, canned foods a lot of times are processed and really high in sodium. So that is a great point. Thank you for pointing that out. Alrighty, so our nursing interventions, what are we going to do for these clients? Because of the potential for volume overload, they're not excreting enough. We're going to keep a close eye on those I's and O's, our intake and output. We're going to closely monitor the electrolytes. So this may look like frequent lab work, especially keeping a close eye on that potassium because we know it can cause cardiac complications. We're going to assess the heart and lung sounds frequently. So lung sounds, we're looking for those signs of pulmonary edema and pleural effusion, those rales, those crackles, and heart sounds. We want to make sure we're assessing for dysrhythmias that are related to the electrolyte imbalances, specifically that hyperkalemia. Now, stages 4 to 5, these clients, we're going to need to prepare for a higher level of intervention. So the prior slide, we talked about management for stages 1, 2, and 3 with diet modifications and our medications that we can give. In stages 4 and 5, these kidneys are not doing their job anymore. They're really not up to snuff here. Once the kidneys are damaged beyond repair, there is nothing we can do to restore their original function. So we supplement. And this can be through dialysis, essentially mechanically doing the work of the kidneys through a dialysis machine that filters the blood externally to the body, or in some cases, the clients will need to resort to a kidney transplant. So with that being said, that sums up our content for the day. Now let's move into our questions to test our knowledge. So question 1 is a diet question here. The nurses taught a client with end-stage kidney disease about recommended dietary modifications. Which of the following menu selections by the client would demonstrate a correct understanding of the teaching? Is it oranges and strawberries? 2 is a spinach salad. 3 is a grilled chicken sandwich, or 4 is tomato soup. So drop those answers in the chat. Let us know what you all are thinking. All right, lots of great answers coming in. Way to go, you guys. And if anyone joined us for our NSNA webinar last week, we are so excited to have you. We will be back with NSNA. These webinars number 5 and number 6 will be September and October. I believe that's September 8th and October 6th, but I will double check on that and get back to you. But again, these are really great. They're 2-hour long sessions, and we cover content and questions, of course, but we also start each of these sessions out with an hour dedicated exam strategy session. We get so many questions and ask for more exam strategy based content, and we're really working to fulfill that. So check out the NSNA webinars. You'll find information on our social media as well as the NSNA's social media too. Alrighty, drop those answers in the chat. Lots of great ones coming in. Someone says they don't like tomato soup, it's nasty. Fair enough. I think it's good on like a cold winter day with a grilled cheese though. I'll stick up for tomato soup for that reason, but totally valid if you're not a soup person. Alright, so lots of great answers came in, but the majority of you guys chose option 3, which was our correct option. So let's look at this question through the lens of what a CKD client will need to avoid in their diet. So with CKD clients, we are trying to avoid phosphorus, potassium, and sodium, and we have a moderate protein restriction. So option 1 says oranges and strawberries. Right off the bat, we know oranges are high in potassium, so we can cross this one off. Option 2, spinach salad. Spinach is a leafy green, meaning it has high levels of phosphorus, but we also know spinach is high in potassium, so double whammy, we're crossing this one out right away. 3, a grilled chicken sandwich. So we're limiting protein intake, but we're not avoiding it entirely. Instead, we're looking for lean protein sources. Chicken is a great source of lean protein. It's not a heavy beef, red meat, steak, sausage. Chicken is going to be a great alternative here. So option 3 was our correct option. Lastly, number 4, tomato soup. Whether or not you like tomatoes, tomatoes are very rich in potassium. Also, canned soups are usually really, really high in sodium. So we would not want to choose this one. We're going to go with option 3, that grilled chicken sandwich. And we are right at lunchtime here, so this is making me hungry. Alrighty, question 2. The nurse is caring for a client with CKD. The nurse notes tall peak T waves on the continuous cardiac monitor. Which of the following actions would be a priority for the nurse to take? Is it administer IV calcium gluconate to the client? 2, teach the client to limit dietary intake of potassium. 3, request a prescription for oral sodium polystyrene sulfonate for the clients. Or 4, prepare the client for placement of a temporary catheter for hemodialysis. Someone asked, why moderate protein? Protein is an important nutrient, which is why we don't want to cut it out entirely, but it is tough on the kidneys, which is why we have a moderate protein restriction, and we try and avoid those heavy, really processed protein things like beef, sausages, hot dogs, things like that. And we swap it instead for lean protein choices like chicken, fish, turkey, and plant-based proteins. Great question. Alrighty, lots of great answers coming in, you guys. I'll give you a few more seconds. Someone says, hi Joyce, happy to have you here. Oh, and Lori Blaine absolutely nailed it. Way to go. So yes, our priority here is to stabilize those cardiac cells, and we do that by option 1, administering IV calcium gluconate to the client. So remember our ABCs: airway, breathing, circulation. These dysrhythmias that this is talking about here is a potassium-based imbalance, which is going to cause cardiac complications. That affects the C of the ABCs, our circulation. That is why it's our first priority. We have to stabilize the myocardial cell membrane, protect the heart before we work to decrease the potassium. So the only thing that's going to protect the heart here, is that IV calcium gluconate. Also, really rapid onset of action, about 1 to 2 minutes it takes to work. Important to note though, that calcium gluconate does not decrease our serum potassium, We're not decreasing potassium by doing this. The priority is to stabilize the heart. So in this case, option 2, teach the client to limit dietary intake of potassium. This is not going to be our priority for a client that's having ECG changes. It's important to teach them this, yes, but dietary intake is going to be very slow. It's also not going to do anything to decrease the potassium level in the here and now. So this is not our priority. Request a prescription for oral sodium polystyrene. Again, this is going to be the GI excretion of potassium, which is a much slower action here. It can take between 1 to 24 hours. And it does not do anything to protect those cardiac cells. And lastly, option 4 is going to be a temporary catheter for hemodialysis. This is not our priority. We're going to want to stabilize the heart before we work to get that potassium off. The client may or may not need hemodialysis, but again, calcium gluconate is our priority because it's working to protect that heart. Other things that we can do later to decrease potassium level include giving an insulin, which we usually pair with some kind of dextrose or sugar source. The insulin will pull that potassium from the blood, shift it intracellularly, and decrease serum potassium. We can give bicarb, can also help with this, as well as a nebulized albuterol can also help decrease our serum potassium. But first and foremost, protect the heart with that calcium gluconate. Alrighty, last question. The nurse is caring for assigned clients. The nurse should first assess the client who has nephrolithiasis and hematuria, an AKI, an elevated serum potassium level, 3, a UTI and pyuria, or 4, CKD with decreased GFR. Alrighty, someone asks, is this a fundamentals question? We are covering chronic kidney disease right now. So we're covering, I guess, the GU system. And this is a priority question. But no worries if you're still in school, Kira. We are happy to have you here. Thank you for stopping in. Let's see those answers, excuse me. And again, this is a more general question. Priority questions definitely challenge you, but we're taking our knowledge that we learned today and we're applying it in a broader sense. I know you guys can do it. This is what NCLEX questions challenge you for. They take what you know or a little piece and they make you apply it in a broader sense. Someone asked how albuterol lowers potassium level. Albuterol helps to shift potassium intracellularly. Can never say that. It's an intermediate onset of action. It's within about 30 minutes, and we would give it via a nebulized form. But it can help pull that potassium into the cell, taking it out of the bloodstream, therefore reducing the hyperkalemia. That was a fabulous question. All righty. Great job, you guys. Okie doke, so I see lots of great answers and it looks like the majority of you guys got this right. Way to go. And I even see some really great rationales here too. So great job, you guys. Option 2 is our correct option. So we want to make sure we are caring for that AKI with the elevated serum potassium level. So we know that elevated serum potassium can cause cardiac complications. They can include things like peak T waves, prolonged QRS complexes. And when we think back to those ABCs, ABC for circulation will be affected by dysrhythmias. So big test taking tip here in general, the word acute in acute kidney injury, this signifies quick change, quick onset, change from the client's baseline, change in status. This is going to signal a need for priority intervention in NCLEX questions. So if you guys ever see something that says acute, new onset, change from baseline, I want you to pay some extra close attention to it. So the rest of the options would be incorrect because they're expected findings, not a complication of the condition at hand. So nephrolithiasis is a type of kidney stone. It notes hematuria, which is just blood in the urine. This would be an expected finding of this condition. While kidney stones can be super, super painful, it's not immediately compromising our ABCs. We would give some pain management, but it's not going to be our priority. Same with option 3. Pyuria is just pus in the urine. This is an unpleasant but a normal side effect of a UTI. This is a sign of a bacterial infection. We're going to treat this client probably with some antibiotics, but again, not ultimately compromising our ABCs in the here and now. And lastly, 4, I hope this one was familiar to you guys. CKD is categorized by the amount of decrease in GFR. So we already know if they have CKD, it involves some form of decrease in glomerular filtration rate. So again, this is an expected finding, not a complication, which is why it's not our priority. But way to go, you guys. Great, great job. All right, we're going to jump to our QBank slide. I see a lot of people asking about previous live classes. Any of our social channels, you can go to any TikTok, Instagram, Facebook, YouTube is the easiest one to search. Every single live that we do gets posted there. So if you joined late, if you ducked out early, you can always see our past content there. Go to any of our social media channels at UWorld Nursing on any of those, and you'll be able to see it. But this is our QBank slide. Again, for anyone that's already using UWorld, here's a way that you can see to get more questions, how to filter them based on exactly what we studied today. And for anyone that has not purchased UWorld already, here's a quick, little look into our QBank and just one of the many, many ways you can filter questions to practice exactly what you are trying to improve on. So a great little reminder. And then lastly, in closing, thank you all so much for staying tuned. I hope you found this to be helpful. The kidneys, the renal system as a whole can be pretty complex. I hope this helps break it down topic by topic. But make sure to check out all of our lives on our social channels at UWorld Nursing. We're going to be back tomorrow at 11 a.m. and 7 p.m. And this week we have ECG on tap, we have oncology, and I think thyroid and parathyroid. So some really, really great content for you all. Have a great rest of your day.